Yeah.
Good morning, everybody, and welcome. Do we have apologies, Jo?
I've received apologies from Zora and Jet and Victoria.
Thank you. Any declarations of gifts received or hospitality which may prejudice discussions further on in the agenda? Thank you. Silence. The minutes of the last meeting. Those of you, I'm sure you've all read them, so does anybody have any challenges for accuracy, please?
No. Move approval.
Thank you. Everybody approve? Thank you very much. Any matters arising? The action log.
So the first one was around our integrated neighbourhood teams and the maturity matrix, and actually there is an update on that in that with the new integrated director starting, Clement. He's asked to pause that work while they look at in terms of looking at the maturity matrix, while they look at the structure and the changes that they're going to make. So I think we just need to hold that. I'll keep bringing updates around the work that's happening as part of the integration report, but in terms of the maturity matrix, they're not going to be doing that for probably not until the autumn now to look at it in terms of refreshing it as well. So there isn't anything more to add on that one. Paul, you've got an update on cancer. If you want to add anything to that.
I mean, essentially the position hasn't changed. The triangulation work we did doesn't seem to demonstrate any increase in emergencies. There was clearly a workshop that failed to conclude. I think, Richard, that may be taken back to the Cancer Board. I'm not aware whether that conversation is carried on at the Cancer Board or not, but essentially it is something I believe the Trust is keeping a watchful brief on.
Thank you.
For the next one around primary care, we've got the focus on the beginning of the agenda around learning disability and serious mental illness, health checks, and the broader piece of work. So that one is complete. Very sadly, we don't have Linda for this conversation. I don't know if David, you've got, or Katie have got anything to add around the conversation at the system exec group, but it might be that we need to bring back a further update if we don't have any comment on that one.
No comment from me.
No. Okay, and in terms of the last two, we've got one on the forward planner around the sustainability, and then we have one that is complete, looking at the circulation of the Menopause Society information.
Thank you very much. Any questions from anybody? Thank you. On the matter of not having Linda, I should have said at the time of apologies that very sadly Linda has decided that she needs to step down from the board and the work of the West Suffolk CCG to deal with the needs of her family, and she's also moved away to facilitate the dealing with those needs, and so she won't be with us anymore. And I would like to place on record our thanks for the very significant contribution that she's made over the time that she's been with us, and we wish her well going forward.
Absolutely.
Ed, a general update.
Thanks, Christopher, and I definitely echo those sentiments about Linda. So just a few updates from me. Firstly, there was an announcement yesterday from the West Suffolk Foundation Trust that its chief executive, Stephen Dunn, will be stepping down. We don't yet know the timing of his departure, but we just wanted to say thank you to Steve for everything that he's contributed to and led on over the last 7 years, and there's been a number of very notable achievements during that time, but also setting up the Trust for the future with the investment that's been secured for the new hospital. So a lot to recognise there, and we wish Steve well in the next phase of his career. Secondly, we've now got a new Secretary of State Health and Social Care, Sajid Javid, who's getting his feet under the table and starting to make decisions that he needs to make. One of the early decisions he's made is around integrated care system boundaries, and he's decided to keep the boundaries as they are in the east of England. So there won't be a change to the ICS boundary that we're currently within in Suffolk and North East Essex, and therefore we can plan on that basis for the launch of the new arrangements in April. So very good to have some clarity after a long period of limbo, which has held back a number of conversations and work. Just allied to that, the recruitment process for the new Chief Exec of NHS England is underway, and we're awaiting a final decision on who's going to be appointed to that role in the next couple of weeks. The three big issues in the health service perspective, particularly from a national perspective, are as follows. So firstly, vaccination, and we're doing very well comparatively in West Suffolk and in our ICS on that. So now comfortably over 70% of our adults have had 2 jabs, and up to 85% with 1 jab. There's a big focus on the 18 to 29 cohort, and I think there are 3 million people in that cohort nationally yet to have had a first jab. So a lot of work during August to improve that position. And we're planning on the phase 3 work for the autumn, where we'll be doing booster jabs, and also looking at how that effort is combined with the flu vaccination work. The big operational pressures are urgent and emergency care, where we're seeing record volumes and demand through all of our services, and everyone's feeling that pressure. As part of that, there's a big mental health element to it, and regrettably, people in a mental health crisis are finding their way to physical acute trusts frequently, so we're having to think about the model of care in that scenario, and also a big concern about children's mental health as part of that wave of demand. As part of that pressure, we have been seeing increasing COVID inpatients in all of our hospital sites across our system, which is a reality of the pandemic, although in the last 5 days or so we're seeing numbers slightly starting to cool nationally, so that's hopefully a very good sign. And then the third big area of pressure is around elective care and elective recovery, where we're working very hard to recover the activity we were doing prior to the pandemic, and we're making good progress in terms of reducing waiting lists and our long waiters, but the overall waiting list is growing. So it's a very pressurized and complicated piece of work, and without doubt it will be a key program of work over at least the next three years, I would suggest. So those would be some of the key things, Christopher. There will be lots of other relevant issues which we'll pick up instead during the course of the papers.
Indeed, and thank you very much, Ed. Does anybody have any questions for Ed at this stage? Okay, thank you very much indeed. Right, let us move on to strategy and service development. And we have a patient story. Kate, would you like to introduce our presenters?
Yeah, of course, thank you. Further down in the agenda today, we've got a couple of papers that are describing the work that's being done with the learning disabilities health checks and the SMI health checks. And a key element to our success in that work is the excellent partnership working that's happening there, which is also work that's echoed in our Alliance paper. So these are 2 excellent examples that the board really need to hear. So I'm really pleased to be able to introduce 2 colleagues from ACE Anglia today. We've got Abby and Chewy with us. who are going to be telling us about the work that they've been doing around their peer educator work with the learning disabilities health checks.
Thank you, Katie. So I am going to be sharing a presentation. I'm hoping it works well. I'm not that great at Teams. Oh.
You got a glimpse?
Yeah, I need to put the computer sound on, but it won't allow me to. It's very strange. Can you see it?
Yes, thank you.
I don't think the sound will work on the video. So if it doesn't, then we'll just have to play it at the end of the presentation with Chewy.
If it doesn't, Abby, I could try and swap it on mine because see if my sound works. Okay.
Yeah,
Okay.
that's fine. So welcome to the LD Annual Health Check Peer Educator Network, which encourages more people with learning disabilities to get their annual health check. So what is the LD Annual Health Check Peer Educator Network? The network's aim is to increase the number of people with learning disabilities getting an annual health check and on the Learning Disability Register. We also raise awareness and give feedback to improve services. We do this by employing peer educators who deliver workshops across the county. The network is funded by the West Suffolk CCG and the East Suffolk CCG. There are 4 peer educators. Here is a film explaining what they do.
Please can you tell me your name? Steve Dunstan. My name is Harry Luton. I'm Stephen Large. My name is Joel. Please can you tell me about your job? My job role is on health checks and as part of the peer educator network. I'm an LD annual health check peer educator. I am doing annual health check and flu vaccine, and we train people with learning disabilities, different subjects like annual health checks. What is a peer educator? Well, a peer educator is teaching the peers on how to get yourself on the disability register, get a health check. They help people in the future to understand the way they should live and that sort of thing, and to help them be more independent. A peer educator is a person with lived experience and to support other people to learn about things which are important to health and well-being and giving other people skills. Once again, many people go through their annual health checks because the numbers always grow, so I'm trying to get it higher so they can find out if they've got any problems or something they can't see. Doctors or nurses can tell people if they're healthy or not. What do you get out of your job? Getting paid for it, and makes me happy and excellent when they're here for me, and they also get a pay for doing it. I feel very important in helping people understand about their rights and their choices, and also I get paid for this. What I get out of being a peer educator is learning to meet new people, going out about what you can't do to different places like community centres and that, like Leading Lives, etc., where people are from people with learning disabilities, and also learning about what it's like to be employed, because we also get paid for it as well.
So, thank you. So the workshops. we started the workshops in 2019. We went all around Suffolk delivering workshops on annual health checks. When COVID-19 hit, we took our workshop to Zoom. We also set up our weekly health meetings, which I'll come on to. So how many people have we reached? Since 2019, we have reached over 1,100 people. Here is a graph some of you may be familiar with. We received this so we could see how our network has changed the statistics in the West and the IES. I will move on to the next slide, which will show the data in a clearer way. Here you can see the combined results from the IES and the West. As you can see, the health checks have increased by 37%, and the amount of people on the LG register has also increased by 5%. Not only in Suffolk. The project has been replicated in Wales. Flintshire have commissioned a local VSO to deliver our workshops with ACE mentoring. NHS England and Improvement also commissioned ACE to work with self-advocacy groups in 5 regions to deliver workshops on the annual health check and the flu vaccine. We worked with Brighton and Hove, Speak Out, Certitude London, Dorset People First, Our Way Midlands, Sunderland People First, and we delivered in the East. Essex CCG has also commissioned an organisation to deliver the work in Essex. What are we doing next? Next, we are going to continue doing our online sessions, but we will be doing face-to-face workshops again. We are going into schools from September to reach younger people from 14. We hope this will increase the younger age group uptaking their annual health check. We also have a family carer session set up in September. So health meetings. Since COVID-19 started back in April 2020, we have been delivering weekly online health and wellbeing meetings. We started off talking about COVID-19, but since then the group has grown. At the health meetings, we work in co-production each week. We have a nurse from the Suffolk Primary Learning Disability Liaison Team, who are Jackie Hammond, Kirsty King, Jerry Newman and Caroline Parmenter. They help answer any questions and support in finding guest speakers and offer advice. The liaison nurses also work closely with us on the network. For example, they help people get on the LD register and inform us of the information we need to know. Dr. Ben Saltway also regularly attends our meetings to offer advice, answer questions, and often delivers presentations. We discuss a health topic each week, which has a different health professional attend. For example, we have recently had Sudbury first responders deliver first aid training. We have had Kate Chait deliver Makaton training. We have had regular meetings about COVID vaccine. The first meeting had 50 people attend. Wellbeing Suffolk also come every few months to offer support and advice. We also have gender-only meetings. This is hugely popular, and we have covered testicular and prostate screening, cervical screening, breast screening, online relationships, and period to menopause. Every topic we discuss is decided by the self-advocates and the peer educators. The peer educator module has also been adopted in other areas. We have worked closely with Leading Lives to create a staying safe online module, and also we are working with the Suffolk Law Centre on a model which tackles discrimination. We are developing a new peer educator models with different organisations. The pre-health questionnaire. Some of you may recognise this. This questionnaire is sent out before people attend their annual health check. The questionnaire has been shared and adapted for Essex, Wales, Great Yarmouth and Waveney, and we are currently in the process of completing one for Dorset. We have also created a generic one for NHS England. And as you can see, a small amount of money has a huge impact and reach. All co-production health resources are on the Suffolk Ordinary Lives and ACE websites. They are reaching people all over the UK and as far as America via social media. And since March 2020, we have been working with the Public Health Suffolk to develop easy read translations on the new COVID-19 guidance and producing short films which have been shared across social media. Thank you for listening. If you have any questions, I'll be more than happy to answer them.
Thank you very much. A most important and useful part of our health system that doesn't always get the focus that it needs. Lisa.
Thank you. I thank you so much to all of you who've presented, because it's so amazing to hear from you guys the work that you're doing and the importance of doing it. I think the Peer Educator Network is just so crucial, so critical. We know that a lot of people get their first kind of health advice from family and friends, so embedding that work into the Peer Educator Network is so important. And I joined one of your Zoom meetings, and the energy and the enthusiasm and the just the support and the collaboration between all of you is just amazing. So thank you. It started my day off very nicely. Thank you.
Thank you.
Anybody got any questions they would like to ask?
I've got one, Christopher, I'm allowed one.
Yes, certainly.
So just to echo what Lisa just said in terms of the work you're doing and the content of the presentation, it is fantastic. Just thinking about the forum that you're sitting in and presenting to, is there anything in terms of using the opportunity that you would like to ask in terms of us, as this is such an important piece of work and you've delivered so much already? Is there anything that kind of stops you being able to do more, or anything that your ambition would like you to explore next that we might be able to support with?
I think what we would be quite interested in is looking at looking at reception staff and sort of how we can sort of maybe train them in some way, because I think sometimes that they're the initial people that people with learning disabilities do speak to in the first instance. So ensuring that they've got the correct information, and if we can help them in any way, I think would be really interested in doing that.
That could be brilliant, because we're doing quite a bit of work at the moment in terms of that group of staff, what their role is, but also supporting them, because I think that they're at the front of lots or all of the conversations, aren't they? And they sometimes don't feel equipped to deal with them. So I think that would be brilliant. Let's take that offline.
Thank you. Next hand is Sally Ryan.
Hi, yes, thank you, Abby. Obviously, I work very closely with the Peer Educator Network. They are so supportive in supporting the CCGs to roll out any quality improvement initiatives that we're running, and it's absolutely vital. They're currently funded up until April 2022, and I think we need to bear that in mind, the important work, the reach that they've already had in terms of getting the information out to people with learning disabilities, empowering people with learning disabilities to support themselves, to access healthcare. I mean, it's just phenomenal. So I just really wanted to sort of reiterate the importance of that work. It really is fantastic.
Thank you, Sally.
Jane.
Yeah, thank you. Echo what everyone else said. Really clear and a really exciting presentation. Can I just ask you a little bit about the numbers? I think you took numbers of people and the reach of it. I probably missed it in the presentation, but I think you spoke about starting off with 50. What sort of numbers are you reaching now?
So with the amount we've reached in total is 1,100 people.
Okay, sorry, but so that's in total, but a sort of a typical event, how many people would you have there?
Okay, so at the annual health check workshops, we run them sort of every couple of weeks, and we have about 6 people come to each one. And then for the health meetings, we have the most we've had is 50 come to a health meeting, but on average we have about 20 to 25 each week, which is on Wednesdays.
Great, thank you.
Thank you very much. Ed.
Yeah, I mean, really brilliant, clear presentation. I guess I was just thinking laterally, in the sense of the increase in the health checks that you've achieved through the peer education. Is there more peer education we could be commissioning for other cohorts, other contexts too? Because it seems a very, very effective kind of methodology that you've got. I'm just wondering how we could spread that more broadly. Maybe we are, but it just seems like such an effective impact that you've had.
Definitely. If anyone, if you've got any ideas, if anything you want us to do, we're happy to get involved. Just seeing Shui's got his hand up, he might want to come in here.
It was only from sort of being, working at ACE for such a long time and seeing the idea of peer, a peer educator has been around a long time, and actually seeing, we talked about it, and then when we came 4 years ago to the actual, whatever it was, to the actual building and sat with the guy, it's just a very powerful thing. The idea has been around such a long time, and to see the guy that's been,
Afraid I think lost.
Project, you think project or something comes up, it's always like project,
Thank you. I think we got most.
Yeah, you get the gist of what I'm saying.
Yeah, thank you, Richard.
Thanks, and Jonathan. You sounded like a bit of a darling towards the end. I think we got most of it. If there was one thing, my standing question with these kind of initiatives, if there was one thing that we could do more of, what would it be?
To improve the uptake, do you mean? Yeah. So the main thing that is brought up a lot is the invitations. Not all invitations to annual health checks are accessible. A lot of people prefer a letter, especially if they've got support staff, because otherwise, if it's a text, the information gets missed. The importance of, and on that letter, the importance of why the annual health check is important, that even if you're healthy, you still need to go, and ensuring that invite is in easy read as well.
So that must be within our gift. Sally's nodding to sort out. And just to answer Ed, we've obviously got Jane here from Suffolk Users Forum, who's going to come on to the next item on SMI health checks. And we've also got the work around dementia checks, etc., where we're working with the voluntary care sector. So strategically, this is a big part of our future, I think, as Ed, you're alluding to, around health checks. There's a big role I think the voluntary care and social enterprise sector can do for us in this. And I think it's something we want to, so we need to put on a recurrent position to give some stability to the voluntary care sector for this important work. Sorry, Jane, I know we haven't spoken about that, but I'm sure it's something we can find some money for.
Thank you. Sally again.
I just only wanted to chip in. We've also got the autism health checks coming in the future, very near future. And so I think that the peer educator model would be something that could be usefully replicated in that group as well.
Thank you. I think we're all very much behind those sentiments, and we'll do our best to make it continue flying. I'd like to thank all our presenters. Very grateful for your time and the effort you put in to making that film and presentation. Many thanks to all.
So Christopher, we've also got James Stevens and Ed Barton and Brendan here.
Some more.
To talk to us about the work that they're doing with the SMI health checks.
Thank you.
Good morning. Hi. My name is Brendan Colton. I'm the service manager with the SMI Suffolk Physical Health team, and I'm here with my colleague Ed Barton, who's the community team manager in the team, and also with Jane Stevens, the CEO of Suffolk User Forum. So we're going to talk about our work together, which basically is looking at the annual SMI physical health checks and the post-check interventions, and basically an example of how we work in partnership to achieve our joint objectives.
You can all see that?
So, but I think Ed, my colleague, is sharing the screen.
Is it working?
Can people see the screen?
Yeah, we can.
Yep.
Okay, right. Okay, so next slide, please, Ed.
You can see the one that says background.
No, it's not moving on, unfortunately.
No.
Try running the slideshow, Ed, might help.
Yeah, good point. Bear with.
Yeah, just to let people know, this was originally a long presentation, so this is going to be an abridged version of the presentation. So we're not going to be looking at every single slide and every single detail on that. Okay.
Oh, you need to go where that little yellow box thing was. You need to click where it says enable edit. That's why it locks it from memory.
Okay.
So
direct. Enable edit. Oh, there.
Enable editing.
Thank you very much. Right.
Brilliant.
Okay, I'll reshare. Bear with me. Okay. Hopefully.
Yeah.
Brilliant. Thank you.
Next screen. Yeah. Thanks for that.
Okay. So basically, SMI Suffolk Physical Health Team, where do we come from? So basically, as a result of the 5-year forward view for mental health and the NHS long-term plan, it was clearly recognised that people with severe mental illness have got health inequalities and premature mortality rates. And the key question was, how do we address that? So what happened was the initial target was set up so that at least 60% of people with an SMI diagnosis would have an annual physical health check in the preceding 12 months. So what did we do locally? So effectively the CCGs, that's West Suffolk and Ipswich and East Suffolk, together with NSFT, the Mental Health Trust, and the primary care practice stakeholders came together and we developed the SMI Suffolk Physical Health Team, which kind of began in the beginning of 2019. So what do? We are county-wide, so we cover both East and West Suffolk. We have 6.6 whole-time equivalent Band 4 members of staff who do the actual annual physical health checks. I manage the team, and Ed and our other colleague Anna are also managers within the team. Our first objective was to try and figure out how we would achieve the aim, i.e. get beyond the 60%. Initial obstacles that we came across were things like the risk of duplication, because the idea of the checks essentially is that we do the work in collaboration with primary care practices. The problem is, of course, how do we know what they've done and how do they know what we've done? So we had to try and figure out a way to make that work. The other issue we had was trying to access primary care practice records, specifically the SMI registers, so that we would know who already had the check and who needed to have the check. And of course, the third big obstacle we came across was the fact that because we are part of NSFT, we use Lorenzo, whereas primary care practices in the main use System 1 and a few still use EMIS. So we had to overcome those obstacles. So at this point in time, we've got very good collaboration with primary care practices in terms of what we do together with them. Ed will talk in a little bit more detail about that. We've developed and evolved our SMI LES on our service specification over time, and our new one has just been approved by the CCG. We take referrals directly from primary care practices as well. So, for example, if there are people in primary care who will not come into their primary care practice for their physical health check, the practice can refer that individual to us, and we will then take an outreach approach to that person, and we will endeavour to see them in their own homes. So we have that sort of symbiotic relationship with the primary care practices, and Ed will delve a little bit deeper into how that works in practice. Okay, next slide, please.
Doesn't seem to want to move to the next slide. Bear with.
Okay.
Hold on.
Take it off slideshow and see if it will move. even if we get it that way.
Sure.
Brendan, if you've got it in front of you, could you talk to it without us?
Yeah, I can
Putting
do.
this slide, that might make it take the pressure off Ed a little bit.
Okay. Okay, so next slide is what is SMI? So just to clarify for people, it's from our point of view, in order to be on the primary care's SMI register, a service user or an individual has to have specific diagnoses, of which there's about 11, but the main ones would be diagnoses including schizophrenia, schizoaffective disorders, and bipolar disorder. So what do we do in terms of physical health checks? When we see an individual for their annual SMI physical health check, as far as NHS England are concerned, we have to undertake 6 key checks, which are measurement of weight, blood pressure, blood lipids, a blood glucose or a HbA1c check, and also assess alcohol and smoking status. If we don't get all 6 of those indicators ticked, then the check doesn't count. So there are must-do checks. We call them the big 6, really. We also, we do, apart from that, we do a very comprehensive physical health check on the individual, looking at other areas, including an assessment of illicit substance or non-prescribed drugs use, looking at diet, nutritional status, medication review. We inquire into oral and sexual health. We assess whether they've had access to national screening programs such as bowel, breast, and cervical. And we also look at relevant follow-up interventions where necessary and where indicated by the physical health assessment. So we do a very comprehensive check overall. So where are we at this point in time in terms of the statistics? You may recall that our initial national target was to get beyond 60%. Pre-COVID, we were well on the way to reaching that target. Unfortunately, since March of last year, checks pretty much went on hiatus as primary care practices focused on more pressing areas, and our team was effectively redeployed into doing other work as well. But we've been back doing what we've been doing best, which is the SMI checks. Currently in England, stats are about 23.4% of individuals have had the check in the last 12 months. The stats you can see in front of you for Suffolk, 32.9%, are for the quarter up to March, but the latest figure is now up to 37.2, so we've made a bit of an improvement in the last 3 months. Ipswich and East Suffolk's gone from 38.4% to 42.8%. West Suffolk has gone from 21.4 up to 27.2. So we're back heading in the right direction. So yeah, things are going well again at the moment, because primary care practices who we do the checks in collaboration with are back doing them again, and we're also back doing them again in earnest in terms of seeing people in their own homes. So it's all going very well. Okay, next slide, Ed. So looking at some of the additional work that we do, and we also cross-reference the SMI register with people who are on the psychiatric wards as well, to make sure that those people are enabled to have their annual physical health check as well. So we pop into the psychiatric wards and we do that there with the patient's consent. We also support the NSFT community mental health teams in upskilling their physical health skills. We advise and guide primary care staff about working with people with SMI and about how to record the information accurately. Ed will talk about that in a minute. And Ed will also talk about how we work to cleanse the SMI registers, which effectively means making sure that they are more accurate and reflect the cohort that we're trying to target. Moving forward, we're looking to increase the access to System 1 for our clinical skills practitioners so that they can directly input the data onto the patient record, and that we can also directly task primary care with any issues that we see as needing addressing in terms of physical health. Moving forward with the mental health transformation model across Suffolk and across the ICS, really, we're looking at aligning ourselves not just with the primary care practices, which we already do to an extent, but also aligning ourselves with the primary care networks, so that, for example, we will align specific clinical skills practitioners with clusters of GP practices. So we've got that sort of ongoing symbiotic relationship with them, and so we become more familiar with our SMI individuals on a more localized level as well. And we've just developed our service spec again, which is great. That was done in collaboration with Jane from Suffolk User Forum and with our good colleagues in the CCG, Hannah May, Emily Rawlinson, Rachel Segal, and Lois Rethal. Okay, we also incorporate useful innovations from other areas, such as looking at having our clinics in more patient-friendly settings. Not only do we see people in their homes, but from time to time we have the option to see people in clinic settings where that's more appropriate. We're looking to expand our staff. We're expecting a little bit of an uplift in funding to kind of align ourselves a bit more with the community mental health transformation model, which will enable us to more align with the PCNs and with the new PCN mental health practitioner teams as well. And we look to expand the partnership and co-production work we're doing with Suffolk User Forum, and Jane will talk about that in more detail in a few minutes. So I'm now going to hand you over to my colleague Ed, who'll talk a bit about data sharing and about the good work that we're doing with primary care practices.
Thank you, Brendan. Apologies about the slideshow errors. I'm hoping they're still big enough for you to be able to read it, despite it not being in true slideshow form. So yeah, there was the first thing we did as a team was to work in collaboration with primary care was to sort out data sharing agreements, and they're in place, been in place for over 2 years with primary care practices. And because, as Brendan alluded to, we use Lorenzo within NSFT and System 1 and EMIS within primary care, it was about trying to sort of share data and access data. So in communication with primary care practices, alongside the CCG, supporting us with that communication as to the rationale for us to have access to systems. Smart card access has been granted for the majority of practices in Suffolk. Certainly System 1 practices, unfortunately, is not so easy with EMIS, so it takes kind of going in person and sitting in front of a computer with a primary care colleague in EMIS practices and going through their data manually in the practice, but we work around that. So yeah, we look at the data, look at the SMI criteria for patients, and a lot of the work over the last sort of 9-10 months has been about cleansing lists, because SMI lists within primary care practices, I've found that about 25 to 35% of the patients don't really meet the criteria for SMI. They've not had any sort of relapse in their mental illness for a long period of time. They haven't had any medication treating their mental illness as coded within System 1 for many years. The NHS England criteria is over 5 years. So if they meet that criteria, then they can have a remission code applied to be kind of taken off the SMI list, so they're not being recalled for an annual check unnecessarily, really, so that your SMI list is accurate with the people remaining on the list who are truly SMI and currently meeting the criteria for severe mental illness. So there's a lot of sort of suggestion work, and most primary care practices sort of agree and accept the kind of suggestions, and we cleanse the lists and make them more accurate. I also sort of looked through comparing the notes on System 1 with Lorenzo, our secondary care record, to come up with a clinical picture, and also determine if the patient is currently under secondary care or only under primary care. And then that can kind of inform where our work lies with that practice. So we'll quite often see the secondary care patients within a practice, and the primary care practice will see the primary care only patients, which obviously avoids sort of duplication. So yeah, there's lots of issues with episodicity as well, where every mental health clinical code within System 1 has to have new episode attached to the clinical code for it to count. So there's been a lot of well, when I started, there was about, out of 4,500 patients, there was about 1,100 patients had incorrect episodicity within System 1. I've got that down to sort of less than 100 or so now. So data sorting has been a big part of it, getting that right, and then knowing which patients you're going to see. So yeah, lots of collaborative work with primary care. Rachel and Emily, who Brendan alluded to, have been really helpful in that. Lots of communication with primary care, email, phone, Microsoft Teams calls, and like I said, practice visits. Wasn't so easy during the peak of COVID. Practice visits were kind of cancelled or postponed, and I've started doing them again more recently. So yeah, we like I say, we mainly focus on the secondary care patients, but we do we open our doors to kind of primary care only patients being seen by our team, despite the patient not being under the care of Norfolk and Suffolk Foundation Trust. They're still an SMI patient under primary care only, managed by the GP, and if they won't engage with GP recall offers to come into the GP practice, we felt that, you know, they're just as entitled to our kind of effective outreach approach to see those patients. So we accept referrals for primary care only patients to be seen by our secondary care team, and we do quite a lot of that. So to try and keep on top of the data and make it as accurate and up to date as possible, I have a kind of rotation system with every practice where I try and complete a review of all the data within 12 weeks and send that to my link, my established link within each primary care practice. So that kind of gives ongoing cleansing suggestions, episodicity corrections, inclusion of people on the SMI list who might not be on the SMI list yet. They might not have met the radar yet of the primary care practice in terms of a mental health clinical code being applied. And we know of them in secondary care with a new psychotic illness that needs to be labelled on System 1, and so that they have the mental health clinical code, and then they're part of the SMI register and recalled for annual checks. So yeah, like I say, we target the difficult to engage patients. That can be quite an effective approach of like establishing a rapport. We can take a few visits to gain trust and educate patients as to why this might be very, very useful for them to have a kind of an annual MOT, knocking on patients' doors. Sometimes that can be ad hoc visits because we've had patients who have no internet, no landline, no mobile, and we'll go and knock on their door, put a letter through their door, and then sort of build a rapport with them. Even take them out for a coffee or kicking a football around first to get them to build a rapport and have trust, and then stick a needle in their arm and take blood out of them. So once the SMI check is completed, we share the information with our secondary care colleagues, so a consultant psychiatrist who might be prescribing you know, medication which they're interested in the impact that is having on the patient's physical health, and care coordinators. And we also complete the relevant secondary care documentation within Lorenzo, and then we share that information with primary care practices. Up until recently, that was a case of doing our own sort of physical health form that we created to match as much as possible the SMI template within System 1, so it was easier for primary care practice colleagues to copy the individual bits of information over to the template within System 1, but a much more streamlined and effective and safer method that we're rolling out now is our clinical skills practitioners having direct access to System 1 so that they can open the SMI template and record directly onto System 1. Also the benefit of uploading ECG results, tasking duty GPs within System 1 about something that might be quite acute and needing addressing that day. So it is much better for patient health outcomes and safer to do that. So we're encouraging primary care practices to consider giving access to our clinical skills practitioners for that reason. So yeah, that's that. Next slide. So making the difference, delivering the identified intervention, because it became clear that it was all well and good doing annual health checks and saying that we're getting towards 60% of patients in Suffolk. You know, that's our aim. Haven't had an SMI health check, but if you're seeing the same patients year after year and you're identifying the same problems with diet, lifestyle, not going for cancer screenings, blood pressure issues, and no intervention is being delivered to address those issues, and you just keep identifying the same problems year on year, then really you're just identifying that, yes, this patient is likely to die prematurely, and we could predict it because we saw them every year on year. So deliver an intervention to make a real difference and give that patient the chance of having more longevity of their life alongside the general public. So yeah, this is where we developed the working relationship with the registered charity and volunteer sector Suffolk User Forum with the project, the Healthy Together Champions project. I won't go into too much detail about that because Jane's going to talk to you about that now, but it's proving very successful, and it does enable patients to achieve physical health and well-being goals. And it's quite often more than just an SMI physical health check. Jane will explain there's quite often other things away from physical health that can be dealt with that inevitably have a beneficial impact upon physical health as well. So it's quite broad, but I'll let Jane talk about that now. Jane, are you happy for me to carry on sharing on here in this format?
Yes, thank you. Thank you very much, Ed. Thank you, Brendan. Yes. So hi, everybody. I'm really delighted to be here. So I'm going to tell you a little bit about Healthy Together. It's a pilot project that only started in February of this year. We were working on designing it in the autumn of last year. And during that time, we've had a steady stream of referrals. We're seeing about 10% of the people that are seen by the physical health team. So that's Ed's team. So we've had 39 referrals to date. We've identified over 50 different referral pathways, and I'll show you what those are in a couple of slides' time. So essentially, people have their annual health check. Ed's team identify additional follow-up needs that people have, and they offer people the opportunity to be referred to our team. People can then choose. So we've made a commitment that we will phone people within 5 days of receiving the referral, and we've absolutely hit that commitment 100% so far, usually making contact within 2 or 3 days with people. We felt that was really important so that people can sometimes forget who they're being referred on to. This mental health system can become very complicated. So we thought if we followed up quite quickly after the referral, then they would have more of a chance of knowing and remembering who we are and why we're calling them. As part of our commitment to Healthy Together, we've also joined Equally Well UK and can also access some of their helpful resources. So I'll just go on to the next slide, Ed, which will just provide you a little bit more data. So what we offer people is individualised support. Now that can mean different things to different people. Many of the people that we're working with, as Ed has already said, would be experiencing quite high levels of anxiety, perhaps feel very reluctant to make new relationships with new people, often live quite isolated lives, often don't have computers or broadband, sometimes don't even have mobile phones. So we try to find out the best way to support people, and we've established really good relationships with Ed and Brendan's team, and the support workers from their team absolutely help us to find the best way to communicate with people. Often that's quite a nurturing approach, so we try to sort of understand from the onset. If we're texting people, if you like, for a first contact, we will text them and say that we understand that they don't always like talking to new people. Would they like to have some conversations by text first? Because I think, as Ed has said, we try to build up a gradual relationship with people. We've had a couple of times where we've made contact with people and immediately they've just hung up the phone. And we had one gentleman we phoned, I think, 4 times, quite a few days apart, and then texted him and sort of said, would he like to speak to us by text first, which is what he preferred. And thereafter, he phones us every week now with a check-in to tell us how he's doing on some of his goals. So I think it's trying to meet people on their terms and communicate with them in the way that they prefer. So when people are referred, they're referred to as to whether they want to be accompanied to appointments, whether they just want telephone or text support. And there's, as you can see there in the support needs, there's 3 people who prefer to meet with us face to face to talk through what their goals are and how they want to achieve them, because they don't like talking on the telephone, for example. So I've given you an overview of the pathways. You will see by far the biggest area of need is dentistry, and the biggest issue there for people is accessing an NHS dentist. And that is really problematic, and often people haven't seen a dentist for maybe 15, 20 years, and actually do have very poor oral hygiene. So in terms of trying to register them, we have managed to register some now, because some dentist waiting lists have opened, but at the very basic level, what we're trying to do is support people with good oral hygiene, whether that's encouraging somebody to clean their teeth once a day, twice a day, or even once a week. It's about beginning to make that start. So we work from the basis on all of the needs that people are referred to, sort of small steps. So one of the other high areas of referrals is around increasing physical exercise. And for different people, that can mean different things. So one gentleman we've been working with, his aim each day is to get out of bed and walk downstairs and to make a cup of tea. And that is his first goal in terms of increasing his physical exercise. And we hope to gradually begin to increase that. But part of that is also about overcoming his fear of actually going physically outside his property. So I think you can see there's very different things. Another lady that we supported on that has actually now gone on to do some of the activities with Green Light Trust outside, in sort of their forest school type activities. So I think there is quite a lot of diversity in people's needs. And as Ed mentioned, along the way, as we build up relationships with people, we find out other issues in their lives. So, for example, we've got one person here with debt problems, but there are other issues that people also have that take a bit more sort of coordination. So sometimes people haven't always been told all of their rights, what they can expect, for example, at a psychiatrist appointment, whether they can ask for a medication review. So it's sort of sometimes the sort of involvement snowballs, and we take the view that there's no wrong door, which has been one of the fundamental principles of the whole of mental health transformation, and that we make every contact count. And I have to say, we've been hugely supported by our growing partnerships really across the sort of mental health system, and in particular with care coordinators in NSFT, who have been hugely supportive. If I could have the next slide, please, Ed. So I've just tried to give you an overview of some of the feedback we've had to date. So we've had hugely positive feedback from service users about our involvement. I've just given a few quotes there. We follow up each of the people we're supporting at 80 days and 190 days after they've been referred, to sort of target when it's best to ask people for their feedback about the service they've had from the physical health team for their annual check, and also the support we've had. You can see that we've also had very positive feedback from the SMI team, which I think people overwhelmingly have found the check useful. There's some common themes we're beginning to identify, which I think as we go forward will help us expand and develop what we do. So some of the things we've found that people have said is they are very anxious about what an annual health check is and what that includes. So we've started talking to a couple of service users about whether they'd like to help us make a video around that, explaining what an annual health check looks like. So I need to talk to Ed and Brendan about that, because I think that might help with some of that anxiety. Also, other things people are saying is that they don't always know exactly who's involved in their life and their healthcare. So we need to begin to look a little bit more about how we can simplify some of the ways we describe who we all are and how we all join together. So that's just a quick overview of feedback. And then lastly, I've just put in a slide on John's story, just to try to explain how we've made a difference in small ways, but with a big difference in terms of an outcome. So this is John's story, which he has sat down and talked to James, one of our Healthy Together staff, about. So John moved over to East Suffolk. I think in the time that he moved, there was a bit of a gap in his GP support. So he was referred to us for GP registration. we had to go out and meet John, and James drove him round his town to help him choose which GP surgery he wanted to go to or apply to be registered with. And then James went through over the phone, filling out the online form for him. And it was only through going for his original appointments that we found out that John had actually been diagnosed as diabetic back last year. And hadn't had any follow-up support for that. So following on from this, he's now gone on and had more blood tests. He's had support around how to eat better in terms of his diabetes. He's had eye checks, he's had podiatry checks, and he's been referred to One Life Suffolk so that he can maybe join some of their walks once they start again. So it's just to give you an overview of how the sort of support develops. And I think that's it. Thank you, Ed. If there's any questions, I'm more than happy to answer. It's a bit of a gallop through.
Thank you very much. Any questions? We do have questions. Richard.
So Jane knows already, but I'm incredibly excited by this because I think this is just a brilliant example of the partnership approach we need between the statutory sector like NSFT and the voluntary care sector. You can see already that it's making a massive difference to those that are part of it. So massive well done to Ed, Brendan and Jane for your leadership within this. And for me, it's where do we go next, really? I know, Jane, I'm always pushing to say, what can we do more and what can we do to support you guys collectively on this? It just shows that when you were talking, particularly Jane, around the level of time you need to put into to support these local residents. With the greatest respect, our statutory partners do not have the capacity and the time to do that, whereas it's clear that you guys and other VCSE partners can do it, can think innovatively about the approach to working with them. And it's something clearly that I think we're all really keen to encourage more on. And I think as the last presentation showed on LD, there's so much potential. So if you look at cancer, dementia, LD, SMI, all those, and there's a whole heap more, where we time and again hear people are struggling to navigate through the system and get the right support, and they just need someone to talk to. There's got to be something, I think, as an ICS and as an alliance in this system we can do even more on. So I think for me, firstly, absolutely a convert, and what more can we do, I guess. The one question I would just on the stats, there was a clear differential between East and West. And it's great that they've improved to 27. I can't remember, Brandon, the stat for East. And I recognise that, to be fair, NSFD are only doing a slice of those. But I suppose it's a question for Jane, Brendan and Ed, and more broadly for the GB. Is there more we could do in terms of that uptake? And particularly, I'm interested, Jane, in understanding, could we look at actually a bit like we had from East Anglia? I think we've talked about this before. Actually, you guys working with us on encouraging the general uptake. So obviously this is the follow-ups, but is there more we could do with you if we asked to do something on, as you say, busting some of the myths about these and supporting general uptake?
Yeah, just a quick one on the stats. I think one of the issues is that we get quite a wide variability in response from primary care practices. Some practices are extremely willing for us to have access to their SMI register to get on to allow our clinical skills practitioners to have access to System 1. That's the kind of the perfect scenario from our point of view, really. I mean, and then you get variability in terms of responsiveness. I mean, Ed is the main man for liaising with the GP practices, but we get a huge variability in terms of, like, let's say, frequency of responses, willingness to work with us, willingness to respond to emails, willingness to give us access to System 1 and so forth. So we work quite intensively with both in Ipswich and East and in West Suffolk with, as Ed mentioned, with Emily, Rachel, our primary care leads, in order to kind of work it kind of in a positive symbiotic way with the practices and to get them to buy into what we're doing, really. And because, I mean, I suppose one of the issues may be that, because practices are incentivized per patient, is there a fear that practices may be a bit reluctant to share information with us? But as far as we're concerned, the people that we would see who they might refer to us are the people who wouldn't come into the practice in any case. So it's not as if they're going to be losing out on the incentive payment for that individual anyway. But by us seeing that individual, we're increasing the overall percentage for that practice and for the area as a whole, really. Ed, did you want to add anything about in terms of some of the issues that we're facing?
Yeah, I mean, you've touched upon it in terms of some practices can be, they get paid per check. So, and obviously if we do a check and share the information with the practice, is for the benefit of the patient, obviously, and better health outcomes, but the GP surgery won't get paid the £124 for that SMI health check because we've done it. So when I have a conversation with GP surgeries, I found this over the last couple of years, and saying we can do checks that you're unable to achieve where you've sent 3 recall letters and the patient isn't coming in. I've found some practices a bit like a dog with a bone, and they'll try for almost 18 months, 2 years to try and get the patient in for that £124. And in the meantime, that patient could be deteriorating with their physical health quite significantly. And we could have knocked on their door 18 months ago and completed an SMI health check. So it takes a bit of kind of persuasion and effective communication and talking about putting the patients first to try and make that collaborative work across the board with every practice. I have proposed, and I'm going to push this further, to propose for next April 2022 for the incentive payment that within the local enhanced service for SMI is altered slightly, and see if there's agreement with this for East and West Suffolk. It's copying a method that City and Hackney do in London, which has proved to be very successful. Their SMI percentage was in the 70%. And basically they have an incentive payment method where the GP surgeries receive payment on percentage of their SMI list haven't had an SMI check. So if they've got 100 patients on their SMI list and they have done 30 have had a check in the last 12 months, that's 30%, you get a payment, then you get a payment of 40%, 50%, 60%, 70%, 80%, and you get a kind of lump sum payment at each of those 10% increments. And therefore it would be a completely collaborative approach, because all of the work that we do would help towards achieving that percentage for the primary care practice. So therefore primary care practices will be open arms saying, please come and see our patients, because effectively you're, not only for the benefit of the patients and better health outcomes, but you're effectively putting money in our pocket as well by helping us achieve the next incentive payment percentage target for our practice. And I just think that would copy, the success that other CCGs, well, the only one that I know in the country, City and Hackney, have done that and proved successful. And I think it's a no-brainer, but it will take quite a bit of work and sort of working out the detail and having conversations with CCG colleagues to sort of push that up the ladder to see if that can get agreed. But that would be the thing when you ask the question, is there anything we can do more? That is it. That is the answer. And more patients will be seen, more lives will be saved, more health outcomes will be positive, less people with diabetes, less people with, picked up with cancers early, things like that. It's very, very important work and can be easily done. We've got capacity to do more in our team, but unfortunately sometimes have to kind of wait for a GP to give us tidbits of work here and there in certain areas, and that can be frustrating for us when we've got excellent staff, really clinically sound staff who do lots of good work.
And I think just to add to that as well, I mean, the other issue is that nationally this has been costed. It's not just a healthcare benefit for people with SMI. There's a long-term economic benefit for the NHS as well, in terms of nipping situations in the bud and avoiding hospitalisations down the line for these people. So it's a win-win really all round.
Thank you. Firaz.
Thank you, Chris. Thank you all for the presentation. My question about a practical side of things, really, if you don't mind, Ed, tell me, how would that work? Who would look at the measurement and the result of the blood? How do you follow them up, and how do you act on the abnormality of the result?
We share all of the physical health check result with primary care in quite a timely manner. So we will, where we can directly input it onto the practices system, such as System 1, we can do that. And we can task within System 1 if it was something that we felt the GP needs to look at and possibly address imminently. But quite often it may be something that we need to bring to the psychiatrist's attention, just as pertinently really, where it's, say, a raised prolactin level and they're on risperidone, and we know that that is probably the likely cause of the raised prolactin level. So we'll still make the GP aware of this, but we'll also send the same correspondence to the psychiatrist and say, you might want to look at the antipsychotics you're prescribing is causing this to their bloods. And that could be addressed that way. And then the GP can kind of rest easy knowing that that is more of a psychiatrist concern that needs to be addressed. And then obviously, ideally, we'd like the psychiatrist and GP to kind of communicate further about that if needs be. So we do ECGs as well, but we use a company called Technomed who the ECGs are done on a kind of PDF, very clever technology, the size of a mobile phone, 12 lead ECGs. They go off to a company, Technomed, and they get a result back to us within an hour or 2 hours of a 6-page report, of a detailed report of what the ECG by a cardiologist. And we get it on a PDF format, which we can then put onto an email and attach in System 1 and attach to Lorenzo, our secondary care record. So, because there were some concerns that we're doing ECGs, who's going to interpret them? But we have a very good Technomed team that we pay £10 per reading, and they do all that for us. And this is very useful, actually. We've identified some significant, problems on ECGs that needed to be addressed quite urgently. So that has been very helpful. But yeah, it's about effective communication, I suppose, with primary care and secondary care colleagues is as important there.
Thanks.
Andrew.
I think this is the most fantastic support to people with severe mental illness, and I think I welcome it enormously. My comment is going to be around a subject which you probably expect me to talk about, because you mentioned dentistry, and once again I've heard that access to dentistry for these very vulnerable patients is difficult, and I'm pleased that things have improved in Suffolk a bit, but this is an indictment of the completely inadequate approach to commissioning NHS dentistry over the last 15 years by NHS England, not by CCGs. Thank you.
Thank you.
Yeah, thanks, Christopher. Firstly, I'd like to echo the comments around this is usually exciting. I think this is usually important. I think there clearly needs to be a proposal on the table that would stop having any barriers to people having SMI checks, because as you quite point out, usually important. But I think my question was around reach. So and the percentage increases. And I think, Ed, you talked quite a bit about cleansing sort of lists. And the point I wanted to tease out was how much of the improvement is done to cleansing a list as opposed to the number of patients you're reaching. Because I think that's the important point for me, is the number of patients you're reaching, not necessarily the percentage of the SMI list. And I think that'd be a clear indicator as to whether or not we are progressive in a positive way, I think, in terms of the reach of patients and the impact we might have on the outcomes of healthcare to our patients.
Yeah, sure. I mean, the cleansing of the list was something that, as soon as I started looking at the data and identified, I'll give you an individual circumstance. There was a man aged 79 years old who, in 1962, took magic mushrooms once and had a hallucinogenic experience, and that put psychotic episode on his System 1 from 1962, and almost 6 decades later he was still on the SMI list and had never been under psychiatric services, never had any medication at all in his life, but 59 years later he was still on an SMI list for taking mushrooms once. So I was quite, suggesting that he came off the SMI list. So examples like that, but the impact of cleansing the list and taking people off, obviously, it may have some impact on the percentage going up, but also some of the people that I'm suggesting to come off the list and apply remission codes have an active SMI health check achieved within the last 12 months. So I'm actually suggesting to take people off who are part of the percentage just as much as taking people off who aren't part of the percentage. So if there was, say, 27% of people have had an SMI check in the west of Suffolk, and I suggest you take these 100 people off, there might be 27 of those that have had an SMI check in the last 12 months. So you're taking off 73 that haven't and 27 that have, so the percentage is going to stay the same. So the percentage going up is more of a reflection of more patients being seen by us, by primary care. The advantage of getting the list smaller is that every health check, well, manageable for accuracy, for seeing the right patients on the right list, but then every health check you do thereafter holds a little bit more weight of percentage. So if your SMI list is only 33 patients now at your GP surgery, as it was 60, there's now 33. Every patient you see is 3% in your practice, as opposed to it was 60, and sort of, you know.
Yeah, and that would lead into your conversation on acne and a different approach. No, that's really helpful.
Yeah, exactly. That then means that you can get to 30, 40, 50, 60% more likely, because you've got a smaller list to work on, and you get a lump sum payment, which is the way I've worked it out with lots of spreadsheets, is that you'll actually have the same amount of potential income from the same amount of success you would have had with the incentive payment per check method, but the difference is our team is helping you to achieve that. So you're doing less work for the same amount of money, and more patients are being seen.
Thank you.
So we'll see.
Steve.
Yeah, kind of following on from that, what do GP colleagues think about the change in incentivization implications of that?
I've spoken to a couple of practices.
No, not a question for you. It's a question for GP colleagues.
Oh, sorry.
Okay. Sorry, I didn't make that clear.
No, that's fine.
Do we have any comments from anybody?
Is it good? Is it bad? Is it unworkable? I honestly have no knowledge.
I'm sure if anybody's had the time to go into the detail of it enough to form a view yet, Steve. I think that's how I interpret this. Oh, Godfrey has. Good old God. Godfrey, let us.
Well, I think my comment will be, I think Ed's been to my practice and done the cleansing, and we've engaged, and the finance of it hadn't been something that crossed my mind at all. But what he suggests sounds sensible. If there are practices who are thinking in that way, then it sort of makes sense to follow the approach in Hackney, I would have thought.
Yeah, I mean, just to add to that, I mean, these are ongoing discussions which we're kind of looking at in more detail. We've kind of shared the idea with Dr. Qureshi as well, obviously, and with Dr. Ross Tandy and people like that. So they're in the know about this as well. In terms of reviewing the model, let's say for the next LES, which would begin next March 2022.
Okay, thank you.
Thank you.
I did gain a couple of bits of feedback from GP surgeries I visited when we were trying to propose this incentive payment method for April 2021. So yeah, this year just gone. But unfortunately, we were having discussions in sort of November, December, January, and it was sort of second wave time, and it all kind of got pushed to the side and thought, okay, let's think about that in April 2022. But I'd spoken to a couple of practices in Ipswich, and they were fond of that as an idea in terms of cleansing the list, having a percentage target to achieve that's a collaborative joint target, and sort of saw no problem with it. It's when I laid it out in terms of the actual finances, it makes sense because it works out very much similar to what it would have been achieved. But you're more likely to receive that money because we're doing more work, we're achieving more work for you, sort of thing, for the patients as well. As the bottom line is that more patients are being seen. So it's trying to find an incentive payment that satisfies the purses of primary care practices, but also obviously gets more patients seen, more bums on seats in front of us. So.
Thank you.
And I think also it's a very progressive way of payment as well. So there are plenty of incentives along the way. So it's not a case of you reach the target and then that's it. You don't get any more payments. There's payments for maintaining and improving as well.
Thank you, Kate.
Can I maybe round us up slightly with the pulling the actions out of this thing, because it's been fantastic, and I think that we've got something really tangible to go away between Richard, Lisa and I to kind of work up, and we'll come back and update the exec and ultimately the board. Jane, it's very lovely to see you, and I'm conscious that we haven't asked the question about is there more that you feel that you can do in this space, and it might be that we take that offline in the interests of time, but it would be really good to have that conversation as well, because the impact is amazing, and the comments in your presentation, there's one in the middle on the left hand side which I can't quote back, but always very emotional, actually, in terms of the difference approach has had on an individual or their partner and their family. That is the kind of change in approach that we're going to need to be able to get the coverage required and the safety for as many people as possible. So it would be brilliant to also have that conversation and maybe bring some of that back as part of a summary or a roundup of where we go from here. But thank you, because that, for all of you, that was amazing.
Thanks, Kate.
Well, thank you very much. That was a fascinating topic and clearly work to be done going forward. Many thanks to all our speakers. Now, in terms of item 7, Lisa and Richard, is there anything else you want to pick out of your papers there, or have we done it absolute justice in terms of the very, very wonderful presentations and discussion that we've had?
No, there's nothing from me. I think the presentation we just heard covered it, and Kate summarised the actions.
For my paper, can I just hand over to Sally, because I think there is a bit of a wider conversation, or just some bits that I'm sure Sally would like to point out around the work that we're doing around quality improvement for annual health checks, and wider actually than just annual health checks. So maybe if Sally could just have a few minutes, Christopher.
Mm-hmm.
Thank you. Sorry, I mean I've actually just done 3 very quick slides. What I will do is I will share the third of the slides, or the second and third of the slides, just to give a little bit of context. So hopefully you can see that now. So in terms of the learning disabilities annual health checks, the long-term plan target is 75% of people with a learning disability to have had an annual health check by the age of 23-24, and that's to include the 14+ cohort. We're aware from looking at our annual health check data that the 14 to 17-year-olds are quite underrepresented currently on our annual health check data. So last year we achieved 63.6 annual health checks for people with a learning disability currently on the register, and that was in West Suffolk, and in Ipswich and East Suffolk we reached 82%. Those figures to me are absolutely phenomenal, bearing in mind that we were in the middle of the pandemic. There were a lot of issues in trying to get people to attend for their annual health checks. So I think that there's a lot of praise that needs to be given for achieving those targets. In the paper that I've written, which has been shared with you all, there's a lot of quality improvement work that's currently being undertaken to support the health and well-being of people with learning disability that extends beyond just the annual health check. So I want to just pull out a few things, and we've already heard from the Peer Educator Network about the brilliant work that they've been doing. But we also have the specialist services support from NSFT. We've got 4 primary liaison nurses. And within the Learning Disabilities and Autism Transformation Workstream, we've invested in the Health Improvement Facilitator Network to really do some work with individuals to try and support them to access their annual health checks and access healthcare in general. And that will include work around identifying the 14+ cohort. There's a lot of challenge in terms of the 14+ cohort. Often they're held by paediatricians, not necessarily seeing GPs very regularly, having reviews in school. And so there's a lot of work that's underway in trying to get that cohort to access their annual health check. The other thing is that nationally, best practice is around developing a dynamic risk register for people with a learning disability around physical health. We've had that in situ for people where there was a risk where they may end up in mental health hospital, but we haven't previously looked at that where we know where their physical health need hasn't been met. So that's underway currently, and that's linked to a piece of work that we're doing where we're doing a real deep dive into the GP registers. We've been given some seed funding from NHS England to really understand the patient's story. Why isn't somebody attending? And then we can work on that individual level to support them to have their annual health check. And then the other part of it was leading on from the leader report that I wrote for you last year, the findings from our learning disabilities mortality reviews. I was asked to look at social prescribing and how that could be linked to supporting people with their health and well-being. We've currently got a pilot piece of work happening in Ipswich and East Suffolk, which we're hoping to roll out across the ICS patch around social prescribing being something that an annual health check leads on to an intervention with individuals around meeting their health needs. So that's a really important piece of work. And the other two pieces of work that I wanted to just highlight was around screening. We know that cancer diagnosis often comes very late with people with a learning disability. Screening is a challenge. We know that there's a high proportion of people with learning disabilities that are ceased from screening services, and that needs to be reviewed. So there's a big piece of quality improvement work happening around cancer screening currently. And then the other pieces of work have been around the COVID-19 vaccinations and uptake. We had very good uptake actually in Suffolk around the COVID-19 vaccinations and people receiving the second vaccination. But I think it sits at something around 85% if I'm correct. But obviously we need to continue that good work that we've been doing. And the other area of work is around the flu vaccinations and maybe looking to link those in with the annual health check. So they were kind of the things that I really wanted to pull out, unless there's anything else, Lisa, that you wanted me to mention in terms of the wider work.
No, thank you, Sally. That's incredibly helpful to talk through your QI projects around that. I think I just wanted to say, and I think I always say this with LD, but with SMI as well, that obviously the health checks are only the first bit, and yes, we just need to keep making sure that all the services we commission, everything that we do, always takes into consideration the access arrangements for people with learning disability and SMI, because I think we're getting better at that, but I think we tend to think of them as a bit siloed, and then we commission services that don't always then think about how do we support access into these services following health checks for people with learning disabilities. Certainly. Thank you.
There's also the joint strategic needs assessment currently being completed by the public health team, which is looking at health and social care, and there's lots of work that's coming out of that. So the action plan, I think, is due to be published around October time. So I'd be happy to report on an update for that piece of work as well.
Thank you. Ed?
Yeah, it was just on the performance side. I mean, as you said, both CCGs have done exceptionally well given the pandemic, but 82% is an extraordinary percentage. So is there something different, additional, that we could do in West Suffolk to get to a similar percentage?
I think that there's lots of work that needs to happen in terms of getting people to attend for their annual health check. I think when we do the deep dive into the GP registers, I think we'll have a clearer picture as to why people are not attending currently for their annual health checks. But also, I think that what happened was that a lot of the annual health checks last year were left to quarter 4 for completion. And actually, obviously, quarter 4 was a very challenging time. And so we need to spread those annual health checks far more evenly across the whole of the year. I think that that's a really important thing. There's thoughts around perhaps inviting people by birthday. There's lots of ways that we can explore that. And I think within the learning disabilities friendly GP practice work, I think we'll be picking up on some of that, Ed.
So did Ipswich Knee spread it through the year rather than
much more evenly? Yes.
Right.
Yeah.
So that's maybe the key learning.
Yeah.
Thank you very much. Right. On we go to item 8. Thank you very much to those of you speakers who are still with us. You're welcome to stay or depart as you see best. Item 8, Lisa, the community engagement group, although I did see David Taylor as well, but who's taking that?
Well, I was going to suggest Dave as the chair took the paper. Thank you.
Okay, thank you. Yes, well, first of all, I have to start by again saying thank you to Linda, and it is with much regret that we find that she's now had to leave us for the reasons you expressed, Chairman. But she will be greatly missed, and her participation and her support of the community engagement group has been great over this past few years. I'm not sure what we're planning to do about a replacement, if we're planning to do anything on that score, given the changes happening. So I welcome any input on that. We haven't met.
Consideration, I think, is the answer to that.
Yeah. Thanks, Christopher. As you know, we haven't met this year, except for just recently. That doesn't mean the CEG members of the West Suffolk CEG group haven't been participating in things, and they've been helping out with vaccination programs and with part of the consultation group, for instance, on the West Suffolk Hospital development, and taking other parts in various consultations. And a number of our members are also part of the PPG groups in the localities, and certainly they have a great interest on how PPGs will be fitting into the new alliance working that's going to emerge in next year. The thoughts that have started to emerge from discussions is certainly a recognition that the changes the CCG is faced with over this coming few months is a challenging one in terms of the timelines that are expected. We will want to do, as members of the CEG, whatever we can to help in some of that process. And so I was very pleased to see that we're planning to have some workshops where hopefully the ideas and thoughts of the CEG members can be included in some ways in which we can embed local patient participation in the alliance working. I think it is of considerable strength, as we've seen from the displays and the presentations today, that where one involves local people, where one involves people who are themselves receiving services, then you can enrich the quality of the service itself and learn a great deal from it. So I'm hoping very much that that will be an opportunity taken when we move towards the alliance working, etc. And the other final bit I'd just like to say is, as I'm sure I'm just repeating what many others will already know, but this last year or so has seen a terrific participation of local people in health support in a very general way. I can only talk about our village, but I know many villages and towns, lots of support has come to offer to people who are vulnerable and to try and make sure that they're okay during this time. And that in turn has also fed into a big support to the health and social care system as a whole. It will be a golden opportunity to really build upon this as we start to emerge out of this current state of the COVID input and see what we can gain from that. Thank you.
Thank you. Any questions? Oh, Kate, further comment.
Please hold comment before me.
Don't mind.
Okay, so I was just going to say.
Also polite.
Well, I'm conscious it's Lisa's item. Absolutely agree, Dave, and I think there is a big piece of work that we need to do to look at that very point of where we've had communities operating in a different way. It was there already, but it's turbocharged now. And make sure that we just don't lose that energy and sense of identity, and also not silo it in terms of individual organisations' approach to engagement. I think if we look at our geography and our localities, we've got pockets of brilliance in each of them, and I think giving strength and empowering that links to the earlier agenda item and my piece in a moment as well, around what are we doing with those community assets and services and people to kind of invest and empower. And it is a new way of way of working, and it takes a relinquishment of some of the traditional ways and some power in some instances, and the building of trust, which I think has happened over the last year, it could possibly be lost unless we do commit to it quite openly. So absolutely welcome that, and we'll come back to you on the kind of what the interim measures for that would be in the direction of travel as well.
Thank you, Kay.
Lisa?
Thank you. And I was just going to comment on the bit in the minutes, Dave, that you spoke about, which is about there was almost a sense of frustration about not being involved with the integrated neighbourhood teams, and how does that all work? And I think we are at a really critical point, and I know Katie and Sophie's leadership have been amazing, but and I think that as we're now really exploring how we will work with our new direction around, you know, CCGs and alliances, I think it's really giving us the opportunity to galvanise ourselves even more in that direction. So I am quite confident that the work we need to do to support at many different levels the public, citizen and patient voice into the health and care decisions that we make within INTS, within alliances and within the ICS is the planning will start. So I think just hold on in there, and I am confident that we will get there. Thank you.
Thank you, Lisa.
Thank you very much. Any more questions and comments from anybody on that topic? Okay, David and Lisa, many thanks. Paul, procurement.
Thank you, Chair. The paper is to note. I'll take it as read, but I guess I will point you to a couple of areas within the paper. So just to confirm that for the children neurological development, we've awarded. We are in a mobilisation process and contract award process, and we will update in due course. We are just making sure that all the systems and processes are coordinated, given the huge opportunity this award represents. In terms of minor surgery, we are in moderation stage as we speak, literally over the next couple of days, and we'll be able to give some updates. And the other elements of the procurement are very much on track as detailed within the paper. The only other couple of things that I would sort of pull out of the paper would be we are still waiting for the legislative changes, and we are engaged in the ongoing conversation with our regional colleagues, see what that would mean in terms of our change to procurement and our approach to procurement. And given the boundary changes that we now have clarity on, we will re-energise our conversation around joining up our procurement expertise across the system, as we'd put that on hold until we understood the decision that was needed to be made. And I'll stop there, Christopher. Thank you.
Thank you very much. Any questions from anybody? Okay, thank you very much. Kate, the Alliance update.
Thank you, Christopher. I'm going to mirror Paul to a certain extent. Like the bulk of the paper is read, but just tying.
Can't hear you, Kate. I think you put your mic.
Yes, it's on a funny play. That's better.
Sorry, I had a drink of water.
That's allowed.
Thank you very much. So what I said really quietly was that I'm going to mirror Paul in terms of taking the bulk of the paper as read, because it's quite lengthy, but just pulling through some of the key pieces, which actually links to the conversation we've been having, almost as if it was planned earlier in the conversation around our work we're doing with volunteering in the voluntary sector. So in section 3 of the paper, we talk about the work we've just started with the college, which is an exciting piece of work, again, sort of on a variation on a theme in terms of engagement, but looking at how we are working with some of our key stakeholders about making sure we're getting the young people's voices into some of our conversation and understanding their experiences over the last year and potentially what they need from the system and the kind of their communities going forward to thrive. So that's a brilliant piece of work, which I've learned so much from the conversations that we've had in terms of how you approach some of these conversations, but we'll bring back the outputs of that to the exec and to the governing body because they should be coming to fruition in the next towards the end of the year and in early spring or the beginning of next year. And following on from that, we've got a strategy that's been pulled together by various partners looking at how we use and champion volunteering. So again, building on David's point, we've all in our own ways really benefited from the value of people stepping forward and volunteering to support during the last year. And what Community Action Suffolk has pulled together, working with lots of different voluntary sector organisations, is a strategy for how we start to operationalise some of that. So making sure we don't lose the impetus that we've got and we don't lose some of the infrastructure that existed already but now has a renewed purpose, but also how we use some of the data to understand. We also have some examples where people have had support put in place over the last 6 to 12 months, which has impacted on their lives in a very positive way. But equally, in some ways, you've got individuals who perhaps used to be able to, who have been shielding, used to be able to perform tasks for themselves and actually have got into a life rhythm where they no longer do that. So it's volunteering, but also understanding what some of the work that's going on in our localities is telling us about the services that we provide as well. So the details of it are in the paper, but I think the challenge is how do we now, as David has quite eloquently said, actually think what does that mean in terms of operationalising that? And that's across Suffolk. So this is a conversation in East Suffolk as well. And the other piece on the related theme is the Voluntary Sector's Charter for Action, which really encompasses, I think, captures what the essence of what we've just been talking about. We know the impact that the voluntary sector can have and the time they can spend within individuals and the outputs that they can get that at the moment and in the longer term, we don't necessarily, we're not able to do that with some of our statutory services, given the time constraints and the limited resources and the different ways of approach. And the voluntary sector leaders have come together and started to, a small group of them has started to kind of articulate what is the ask. And this went through the system exec group in July, and there was strong support for it, and it will do the same in East and at the ICS board as well. But I think it's section 5.4 where they just have a list of asks which we've agreed to across the ICS to understand a little bit more detail of how we operationalise them. And it links to the stuff that we have been talking about for a long time around the funding for the sector, what the model would be and how where we've got different funding models across different organisations in the system, how we align them and just give that longer term footing to the services so that we can develop them and understand how they fit into our broader commissioning model. And we definitely do this already, but it is about, I think, taking it to the next level. And they're also understanding of how difficult it can be in terms of commissioning from a very varied sector and looking themselves at how that they could play a role in making sure that they're able to do more to share their back office functions, to be able to to demonstrate value for money, return on investment, and share things like trainings and some of the core purposes, so that they also can start to operate slightly differently in terms of what they can bring. What they can bring in terms of a service offer, but also how they can develop themselves and make the most of any investment that comes into the third sector within our system. So the whole paper is included. So it is worth a proper read, and I think it impacts on all of our departments, all of our portfolios in terms of the commitment and where we go from here with it. And then the last point that I just wanted to draw attention to is conversations that we've had around data and digital. I think as we're moving with the changes as part of the white paper and understanding, looking at moving to an integrated health and care board, and managing the preparation for winter and just the operational oversight. It's very clear that there is more to do in terms of joining up our data and our digital offer, in terms of how we use information, how we manage risk as a result of that. And I think we had some very strong conversations with our leaders in those fields about the appetite to join up and to share in a different way. And I think we've made great strides there, but there is, how do we take that on to the next level? And again, that's something that we would do across East and West and North East Essex as well, because I think we need to have that local grip on data, but equally the infrastructure is broader than that as well. So that's also part of the ongoing conversation. So they're probably the key pieces I wanted to pick out. Happy to take any questions.
Thank you. Ed.
Yeah, thanks for the paper, Kate. I was wondering if you could say a little bit about community pharmacy. There's obviously an area of the service, if we can put it that way, that have really stepped forward, I think, in the last year. And there are a couple of statements in the paper about the relationship between the community pharmacy and the PCNs, for example, becoming more integrated. I'll just say this because I was interviewed to talk about community pharmacy recently, which kind of helped crystallize some thoughts I had. So I'm just keen to know what your view is and what's progressing locally.
Brilliant. No, thank you. That's very timely. And maybe just to be able to formally say in a public board meeting that from the vaccination programme's perspective, I think community pharmacy has played a really key role, especially where we've had gaps from our West Suffolk footprint. Being able to step in and provide the service has been invaluable. And I think what it's done as well is given a lot more detailed knowledge and building relationships within the kind of locality spaces where we've got providers who for a long time I think have been saying we have capacity to do more, but again it goes back to some of the trickinesses around the contracting methodology and how services are run. And I think what the vaccination programme has allowed us to do is to cut through some of that. And we had a work which is detailed in the paper. We had a workshop to talk through what are the potential pieces of work or kind of the broader role that we could get community pharmacy involved in and sort of growing into that space, recognising the challenges. And there is a lot of historic challenges which I think we've cut through in the last 6 months, but need to be unpicked from a contractual perspective. But we are in a position as a system, as a country, where we have a significant challenge around making sure that we've got the right service offer for our population. And this is a part of our system which is very willing to do more and has the capacity to do more. And I think there's a list in the paper. It's understanding what those areas are. And there's a lot of national initiatives already underway. And it's for us operationalising them in probably in advance of winter for several of them, but operationalising them in a slightly different way than we have done previously, where lots of that has sat within public health. I think it's sitting much more within that kind of business as usual conversation from an operational perspective locally. I don't know if anybody else would like to add anything, because I think you've got a lot of people who've got views on community pharmacy. Jeff, is this related?
Not really, no.
No, I didn't think it was.
No.
Just before we have Jeff, then, anybody want to make any further comments on the contribution of community pharmacy, either to date or going forward? Okay, thank you. In which case, Jeff, can we change the subject slightly and move on to your point?
Thank you. I mean, there's been a great number, vast numbers of volunteers linked to the vaccination programme. I'm just wondering how we're going to capture that going forward, because I'm sure lots of those individuals would like to continue volunteering. And I mean, it's a great capacity that can be brought to the system. So I just wondered how they would be captured going forward. And the charter, if I went back 10 years or more, all of that plays out yet again when I've been working for the voluntary sector. It's not new, but it's some of the things are intractable or we don't seem to be able to tackle. But I do agree there are issues I think the voluntary sector has got to do as well, which you raised, Kate. So thank you.
There's not a clean answer to the volunteering piece for the vaccination programme, but you're absolutely right. I think it's been phenomenal, the response that we've had from our communities to support the vaccination efforts, and I think it's been a two-way relationship as well in terms of what people have got from the experience. And I think the vaccination programme isn't going anywhere. I think that will continue. So there is that space, but I think it's also shown the relationships that our practices and our primary care networks have with their local population. Again, just linking it back to the engagement piece, the reach from a community perspective and the role that our practices play in our community's life, I think has to be at the core of the volunteering piece as well, because I think they, if we're going to not lose people who've kind of stepped forward, I think our PCNs are going to be a key part in making sure that we can kind of keep communicating out where we've got opportunities to continue with that. But that is also part of the broader engagement piece as well, which Lisa and team are leading on.
Thank you, Ed.
Just to reflect back on Jeff's comments, I mean, one angle on this is the workforce. So there's a number of volunteers who've been trained as vaccinators in the NHS England vaccination centres, a lot of people. So there's a debate I think we need to have about how we continue to support and work with that new workforce, which we didn't have previously. So I think we do almost need a stock take from a number of angles of how we keep going if possible as the context continues to change in the future, because capacity is an issue, and I think we need to take every trick that we've got.
Yeah, thank you very much. Anything further? Okay, thank you very much. It's obviously all zizzing along. Now, I propose that we take a break before we get to the next section. So could I suggest that we reconvene? Can you manage 11:15? Yeah, so that's just long enough for you to get your kettles on and do whatever else you consider necessary. I'll see you then. Cameras off for the break, please.
Coffee now. 8 minutes.
Right. It's difficult to know, of course, who's back and who's not, because not everybody's picture is showing, but I think we should move forward and move on to finance, performance and scrutiny, starting with the performance improvement section.
Thank you, Christopher. Do you want me to start us off?
I think that would be great. Thank you.
Okay. Christopher, if I may, the new system oversight framework has now been published. So I'd like to spend just a couple of minutes going through some of the key points. I will, of course, circulate the relevant papers with the minutes of this meeting, but I thought it was an opportunity just to appraise the board of some of the slightly changed direction that the paper indicates. And then I'll move on essentially to some of the key aspects of the paper, in particular focusing on the elective activity piece that Ed has already brought up in his summary of issues. So the new system oversight framework has just sort of come out of its final consultations, now been published. It seeks to give clarity as to how NHSI and E will monitor performance at system, CCG and place level. It absolutely reinforces system-led delivery and integration of services. So again, the conversation we just had with Kate around the alliances, place, and the sanctity of the importance of how services will be delivered is been made very explicit within document. It does describe a far greater collaboration with national bodies such as CQC. And again, Lisa previously in some of the comments described the increasing involvement of CQC in terms of performance and quality framework. So it's very much in synergy to that. I think importantly, it replaces special measures, which is obviously when an organisation is in difficulties, whether at system or organisation level, but by a recovery support programme, an integrated report programme, which is essentially bringing on board the likes of NHSI, other performance improvement and other bodies nationally to support organisations who are finding themselves in difficulties. Again, that'd be very much with the conversation with the system, but essentially it is an attempt to try and have a much greater focus on improvement and support rather than punitive sanctions as an approach. So again, a really welcome change of approach that the paper indicates. I think it's important to say that so performance and leadership will be measured across 6 main domains, which are broadly quality and outcomes and access to services, people, leadership and capabilities, prevention of ill health or health inequality agenda, in particular, finance and use of resources will be absolutely key, and local strategic priorities. So it very much is cutting the performance element in those elements and those focus. I think as a system we're really well placed already because much of our structures reflect many of those elements. But again, we need to take some time now to reflect on that and make sure they are fit for purpose as we move forward. The whole thing is now underpinned by roughly 70 KPIs. And when you look under the KPI, there are more, of course, that is always the case. And I think that gives us an opportunity to really review how we report our IPR. So again, one of the focus between now and possibly the next set of governing bodies to see how our current IPR, current reporting fits in with that current guidance that we've just received from the system of that framework. So as I said, I will sort of circulate essentially the relevant papers with the minutes of the meeting, and be happy to bring something back at future meetings in terms of how that might start to structure. The last point I would make is that, of course, this will change because this is actually a precursor to system work in ICS structures. But actually, I would suggest that the structures that are being identified within the paper are very much here to stay. They'll just be tweaked as we move forward. So I'll pause there for a second. Happy to try and answer any questions on that particular element, but I just wanted to pray that there'd been a change nationally.
Thank you.
Okay. Can I move on?
Yeah.
Thank you. Cheers. Thank you. So again, as Ed has described, elective sort of recovery is certainly one of the very key national focus. And as you recollect, we are one of the accelerated sites nationally, two within the region. And essentially, we have committed to hitting 100% of our threshold activity based on 1920, and then moving on swiftly to about 120% around October. As you know, as a system, we face some significant challenge around some of our RAC issue, in particular around some of our capacity consideration that we have, and we are taking those into consideration. So I'm sort of pleased to report that we've got a fairly high level of confidence that as a system we will reach 100% by the end of July. It is marginal, and it has been a lot of hard work and a lot of focus, but the early indication that we should get there, and then quickly we will move on to other elements to try and reach 120%. And interestingly enough, there has been some regional national modelling that suggests in order to recover our waiting list within the next couple of years or so, we probably need to be operating about 126%. So again, under 20% feels about the right level. The key issues will be one, the sustainability, workforce, etc. And I'll touch on that in a second. So in terms of the early indicators of our elective recovery and how that fits into the IPRR, we can see that as a system, greater than 1 year patients have dropped from roughly slightly over 7,000 patients to slightly over 4,000 patients. So we are seeing a reduction in some of our over 52 weeks, which is good news. The question would like it to be quicker, of course. In terms of our over 52-week waiters, we were averaging about a 92nd percentile, about 53% back in May, and we're now at 44 weeks. So again, we are seeing a reduction in our over 52 weeks. The slight complication to all of this is our ultra long waiters can be problematic because they are quite complex in what we try to achieve. But we are monitoring that, and we are seeing some very slight reduction in those and putting some focus on some of that. As Ed has previously stated, our waiting list is still growing. And you'll notice in the IPR pack, we are still seeing some growth in our waiting list. What I would say on that is our waiting list is growing slower than if we'd done nothing. And again, that's important. So we would, for example, of maybe predict an average growth of 8%, but we're seeing about a growth of about 3%. So again, right movement in the right direction, but actually a lot more work to do. And as Ed has alluded to, this is a 2 or 3 year program. This is not going to happen overnight. So clear focus on prioritization of patient continues. We are also monitoring some of the cancer elements, and for West Suffolk in particular, we are seeing a reduction in our long wait around cancers, which is great news, because the capacity is unlocking some of our ability to deliver the care that we need to deliver. However, I do need to point out that there are some still real risks that are attached to that elective recovery. One is workforce, because actual capacity means greater workforce or make some of our workforce work more smartly or harder. And there is clearly an element of sustainability within that. So the clear focus on our people board and everything we're doing is really quite key and important. We are clearly seeing some rising demands, in particular on emergency care, and we are having some focus on that to understand what else we can do. Clearly, emergency and elective are the same two sides of the same coin. You know, if you get overrun by emergency, it limits your ability to do your elective work, etc. So again, some really important focus on emergency care is needed. There is a risk around our COVID activity. So we are seeing some increase in our COVID patients. In West Suffolk, I think we've gone very quickly from about 4 to 5 patients to about 9 to 10 patients in the last weeks. Whether or not that is going to carry on or not is a bit unpredictable. We are keeping a very watchful brief and planning to manage and cope with that. But clearly, if that carries on in terms of peak, then that will have some consequence to our elective activities. So again, some work ongoing with that. And finally, just to appraise the board, there has been some changes to the ERF structure, which is the elective recovery funds. Previously, the target was 85%, at which point you'd get 120% of tariff. Now that has been changed from 1st of July to having to achieve over 95% before you get any actual funding, and then 120% only when you've reached 100% of threshold. Now, that is something we are managing. That is something we are discussing. Don't think it necessarily will derail us, but it is a financial consideration, and I'm sure Jane will agree. So we just need to unpick what that will mean. The bottom line and the reason for that is essentially the pot money nationally that was set aside has been overrun because actually most areas in the country have recovered much more quickly than was expected. So again, some decisions have been made nationally, but I just need to flag up that there is clearly a financial risk attached to some of that and the ongoing conversation into the second half of the year. So in summary, some great work, a lot further to go. Quite a complex program, which would take us the whole of the board to discuss, which I don't plan to do, but actually really to broadly summarise additional capacity, real focus on productivity on what we do, real focus on workforce, the sustainability are the key elements. And there are now some ongoing conversation with our national and regional teams around what else can we do in terms of what the appetite might be internationally in terms of doing something else. So again, a real focus, which is not going to go away quite rightly. So I'll pause there for a second. If people want me to ask a question, I'll move on some of the key elements of the report. Jeff.
Thank you, Paul, for that update. Very helpful. Two things from me. What's the balance, if you like, between in-house increase in activity and out-house, as in putting work out to the private sector? And secondly, where we've got regions, I'll use that as an example, which are much further on in achieving recovery, are there going to be any differential targets to help those that are behind the curve for good reasons nationally?
So I think again, I'll use Kate's answer. I don't think there's any real clean answer to your question. I think first of all, in terms of target, I think part of the accelerated program has been essentially for, I suppose, regional national team to start getting their heads around in terms of what targets they're going to set. So if you recollect in previous meetings, I talked about gateways. And gateways are essentially a way of making sure that systems achieve certain set of transformations. So things like PIFU, patient-activated follow-ups, things like advice and guidance, things like joint PTLs, joint waiting list management, things like collaborative working, things like health inequalities, are all measures that essentially have been tested in the first 6 months. I fully expect that as we go into the second half of the year, there'll be some more hard-edged targets for us to achieve. I think we're in the making. Now, the fact we're an accelerated program, we are contributing to that conversation. So again, Ed and I and the Trust are attending a national meeting today to talk about lessons learned. And I'm sure out of those conversations will come a shaping of what we might expect. The issues around finances are really unclear, unless Jen can update us, but clearly there will have to be a conversation about additional funding. The way it's structured, the way it's apportioned, I have no idea at this stage how that's going to pan out. But clearly, if we are going to be expected to achieve 120% plus of our previous sort of 1920 activity, then it can only be achieved in two ways. One is productivity and efficiencies, and the other way is additional funding. And it'll be a mixture of those things, I suspect, as we move forward. The Axel decided to simply give us a glimpse into what might come across over the horizon. Does that answer your question, Jeff?
Yeah, in the main, I was just wondering how much of our extra activity is being done by the private sector or the independent sector, because our independent sector is probably quite small.
Yeah, so you're absolutely right. As a system, we are absolutely maximising our private sector, and if you look at the North East Essex side of things, absolutely a lot more support because there is simply a lot more capacity. We are working very closely with BMI. And having ongoing conversations and actually having some activity, and I can let you have the figures in terms of how much activity is going through that, and that's in part how we're going to achieve the 100%. We are also maximising our other private sectors around ophthalmology in particular. We've doubled the number of patients going through, and we are fully utilising the private sector framework where it is feasible for us to do and required us to do. So again, part of the forward moving is a continuation of usage of private sector. The only thing I would add, Jeff, just on the point, which I know is not specifically about private sector, is a conversation now is much more about joined up working. So SNF are currently doing a bit of ophthalmology work from West Suffolk to support the differential in waiting list. There are some clear collaboration conversation around orthopedics in particular, where we've got some particularly sort of a long wait issues. So we are starting a much more sort of a joined up discussion at system level in terms of managing our waiting list.
Thank you. Ed.
Yeah, this may be more of a question for Amanda or others, but on the productivity piece, obviously the staff are working extremely hard, and there's a sustainability issue around that, as you've referenced. But is there any work that we're doing or need to do around workforce redesign in terms of, upskilling nursing roles or whatever it is, just to find a way of keeping the productivity going? Because the reality of this is to, as you've described, to really make headway over the next few years, we're going to have to get to 120%, 130% consistently at baseline. And it's just a massive sustainability issue for the workforce, isn't there?
Thank you, Ed. Let me come back on that if I may. So totally agree. A mass agenda that the People Board and the HRDs are talking about and trying to action. We have improved the governance around our People Board in terms of the wider health and wellbeing and burnout agenda. And on the latter, we are looking at burnout metrics to support the system in terms of better monitoring and the like. But there is more work to be done, Ed, and is something that I'll be regularly reporting back to through the Accelerated Programme Board in a couple of weeks' time.
But is there anything specifically on the redesign of roles?
Nothing concrete at the moment, Ed. I think it's fair to say live conversations are happening.
Okay. Lisa?
Thank you. I'll just come back on that point as well, because I think there's a huge amount happening within organisations on redesign of roles, with the nursing associate role that's now introduced, and we've seen the first cohort qualify in Suffolk, but also Sue Wilkinson, Director of Nursing at West Suffolk, and Giles Thorpe, Director of Nursing at ESNEF, jointly chair an advanced practice forum. So they are looking at the structure and the pathways and the future needs of not just nurse practitioners, but clinical practitioners, so AHPs. And that would be a great forum, Amanda. They've only had 2 meetings, but they're really streamlining and getting an ICS kind of agreement around the ACP roles. So there's a group already formed that could help with that work that they're taking the lead on.
That's great.
Thank you.
So,
if I may, the only thing I would add to that is clearly there is ongoing and being completed extensive review of the 29 pathways which have been dictated nationally. As we review pathway, Golden Open, you start reviewing new roles alongside that to deliver new pathway of care. So again, linking those things up together, I think would probably be really helpful.
Thank you very much. Kate?
Just seconding what Lisa's saying there about the ACP piece, I think the biggest challenge there with that piece, and it's a long-standing piece of work, is the cultural change required. So I think being able to really use this to push, we are going to have to, as Ed's saying, look at roles differently. That's one thing. The other piece I just wanted to add to what Amanda was saying is that we're bringing together the workforce groups that sit underneath the People Board from East, West and North East Essex to kind of look at, from an operational, especially going into winter and with the elective care recovery, what we could do across the system. So that's also looking at the reablement roles, the home first roles, the use of volunteers. So this is for kind of a pre and post admission, so that we can just reduce that length of stay and also make sure that the ripple effect into the broader system in terms of people needing packages of care is also managed. But the energy around that conversation and bringing, because that's made up of AHPSs as well as kind of more of the frontline teams that can then feed up into the People Board. I think we've got off to a cracking start. So again, bringing some of those other conversations through those forums, I think will help to fuel it as well.
Thank you very much. Okay, shall we move?
So
is that yeah?
Yeah, Christopher, if I may, so just to conclude the final bit, I think we sort of talked around it, but right now into the performance, we are absolutely focused on the emergency side of things because we are preparing for winter, which is likely to be quite a difficult winter. We have got a workshop coming up next week with the whole system to talk about what else can we do. I have to say, despite the pressure, we are doing relatively well compared to other systems who tend to be at level 3 and 4 at the moment, while we're at level 2. But that's not decline the hard work and the pressure that the whole system is finding itself. But we can always do more, and we're having those active conversations as we speak. We're also sort of redoubling our effort around some of the community elements of services, in particularly CYP and autism services with West Suffolk, because clearly the pandemic has caused some difficulties, and we're having conversation about what next steps might be to recover some of the performance there. The only thing I would add in an area we don't often talk about is ESEC. Myself and Lisa met with a new leadership essentially before I went on leave to talk about how we could have greater collaboration around understanding the quality issues and also the performance issues, and developing a local presence of ESECs in terms of leadership. And a workshop is being established, and I don't know if you can remember when, Lisa, but pretty soon, in terms of having those discussions alongside some of the performance contractual conversation we're having, which I thought was a really positive start to a conversation.
Thank you.
And I'll stop there.
Thank you. Any more questions for Paul on that section? Okay, clinical quality, Lisa.
Thank you, Chris. I won't go through each organisation because there's some detail in there, but I think really the biggest quality challenges relate to exactly what Paul said. It's around supporting organisations through the demand and capacity piece of work, and the other organisation is the Ambulance Trust as well, because they are facing some real high demand and work. I've been working with Juliet, the Director of Nursing, and the other CCG ICS dons and provider dons around making sure that patients remain safe during that transition from ambulance service into emergency department. But obviously, so from West Suffolk, I'll just talk maybe about West Suffolk. Maternity work is continuing. We signed off West Suffolk's continuity of carer rollout plan at an extraordinary maternity board last week, and they are predicting, and it's only a prediction because it could all change. It's all very dependent on workforce. But they are predicting to have full 100% continuity of carer rollout by next April. So that is amazing. ESNEFT are planning to start next April. So it just shows how far ahead within our ICS West Suffolk are, which is great. That does kind of raise a few issues for patients who are registered with GPs and will have continuity teams from ESNEFT, but actually wants to deliver at West Suffolk. So we're just trying to establish a process whereby it would be great if continuity of carer teams from both sides of the county could follow the woman into whatever hospital they choose, rather than having an entirely new midwifery team, obstetric team as well, once they access delivery. The other piece of work on maternity is we are renewing our call for women who are pregnant or women who are planning to become pregnant to come forward for vaccination. There was a national meeting yesterday in maternity that's looking at some of the workforce challenges and some of the demand challenges we currently face in maternity services, but also in other areas. We have seen an increase in women during pregnancy being admitted to critical care units with COVID. So we've done some work. We did a great webinar that was really focusing on the Royal College's advice, but with Simon's support and our providers' support, we're really focusing on making sure that women who are currently thinking about getting pregnant, as well as women that are come forward for vaccination. West Suffolk have signed off their quality. It's kind of a quality account time for my team. All the providers write quality accounts. We, as CCGs, need to go through them to make sure that all the statutory bits are adhered to and that we agree with their quality priorities. For West Suffolk, they have 3 quality priorities for 21-22, and I'm really pleased actually because they're looking at the infrastructure and culture rather than specific QI projects, if you like. So the 3 quality priorities that West Suffolk have are around supporting colleagues to speak up safely as part of a culture focused on staff support, wellbeing and learning. So really encouraging that safety culture, which is great to see. The learning and improvement through the implementation of the new NHS patient safety framework, which is a massive piece of work for them, and the development of a reporting framework for quality so that there's real clear governance through all pockets of service delivery up to the board, which again, I think will serve them well. NSFT is probably the only other organisation I'll just briefly mention, which they also have produced their quality accounts, and their 3 quality priorities are to increase their number of friends and family responses and use their data to make a real difference, to address physical health inequalities through better integrated care, and the SMI work that we heard about this morning is a great example of that, and to be in the top quarter for quality and safety by 2023. So we'll look forward to seeing their improvement along that journey. I think that's all. Thank you. Unless anybody has any questions. Thank you, Christopher.
Thank you. Any questions? No? Okay. All very happy then to move on to strategy and transformation. Where's Richard? There's Richard.
Yeah, thank you, Christopher. So just a brief update on some of the main programmes. So in terms of elected care, Paul's already given the main elements, but just to say we've got our first meeting of the West Suffolk Elected Care Revised Group tomorrow, predominantly with it from Trust Folk, given a lot of the work streams Paul's outlined, but we'll be talking offline around GP representation into that either via the PCN, CCG or both. So it's just the first kick-off meeting really to take stock of the programme. We've also started the musculoskeletal and eye care programmes across the ICS. So we've had kick-off meetings with the region to set out our stall, so to speak, from the clinical leads from across ESNEFT and West Suffolk FT alongside ourselves on what that could look like. And we've had the first MSK programme board meeting last week, and we've got the eye care one coming up in a couple of weeks' time. I think I've seen a movement on both of those in terms of some of the appetite for cross ICS working. And I think it's been really, in one sense, it's been really helpful, I think, the national push, and I don't often say that, to actually mandate that these 2 areas need to be looked at. To be frank, there are 2 of our biggest referral areas, and we've got some of the biggest differentials in wait times. Having said that, we also need to look at the whole pathway, not just the acute element, but actually particularly for eye care, there's an appetite following the workshop to look at what more we might do with our community partners. So I'm quite excited with some of the potential developments in that area. And Paul's already alluded to the high volume, low complexity pathway work, where West Suffolk have done a 80-page pack setting out exactly where they think they can start to make some differences on those 27, 28 pathways. And again, we'll be focusing on some of that at the elective care meeting tomorrow. Not a huge amount to say that's not already covered in the Alliance report from Kate and Paul on the UEC challenges in relation to all of our integrated care agenda. Just to reinforce what Paul's saying around the challenges around UEC and the workshop coming up next week. On children's and young people, we've on the CAMS front, we've now got the model and the specifications pretty much bottomed out. Our challenge at the moment is more of the immediate pressures within the emotional wellbeing hub, and we are looking at alternative mechanisms for managing some of that demand at the moment. So we'll be updating the clinical executive in due course once we've got something more concrete to share. We've also got the outputs now of the Children and Young People Community Paediatric Service review that we commissioned an external partner to support us on. and we'll be looking to bring the recommendations and an accompanying action plan through to the executive meeting in September. But just to give you a sense, one of the main recommendations coming out of that, which the sponsors of the work all agreed, including Helen Beck within the West, is that we need a CYP strategic plan. So we've got lots of work happening in the children's landscape, but it feels a little disjointed and it's not clear how it all hangs together. So we are looking to do a piece of work, not a huge piece of work, because a lot of it we've got, but pulling that together into more of a clear plan at both county and place level in terms of where we move forward in terms of our ambitions for children. And then finally, just on mental health adults, I'll be bringing a more comprehensive paper to the September board, Christopher, outlining some of the specific progress. We normally do a quarterly report on that. But just to say, on the community mental health model, we've actually made some good progress in the west of the county, not that it's a competition, in terms of the recruitment of the mental health practitioner roles that are providing much needed capacity in terms of our new mental health model. And there's a big thank you to both NSFT and the GP Federation for their support in taking that forward. Oh, and I must not forget cancer. Paul alluded to it, I think, earlier in the agenda, but we are looking again with a renewed focus at both the breast pathway across the ICS. There's a quite an innovative model that the Nottingham system have got in place, which is one of the best performing systems in the country on this. So we are looking and working with Professor Robertson, who leads that service, around whether we can replicate that within the Suffolk North East Essex system. And I should also mention again the strength of the Macmillan navigators, particularly in the west of the county, where we've confirmed with West Suffolk that we will be both part funding the ongoing commitment to that, which is a welcome development. Happy to take any questions.
Thank you. We have Kate, first of all.
It's more of an addition rather than a question. I just wanted as a observation on the community mental health model, because it is a brilliant piece of progress in what was a very difficult situation. We're not there yet in terms of getting the post fills, but we're making very strong progress. And I just wanted to, one of the points of difference at the moment, or what feels different, is we've got either Mark Patterson or Vanessa Ragg, his deputy, coming to our clinical director conversations quite routinely and collecting things to go away with that don't just relate to community health to come back, and it's just the relationship building exercise, which I think is helping to underpin the broader piece of work as well. I think it's a good news story, which hopefully we can do more than just the community model with in terms of that relationship.
Thank you. Lisa.
I just wanted to say that, and I know this is happening because we now have a maternity and CYP MDT within our organisation, but we're also developing the maternity strategy for the LMS and supporting providers on their own maternity strategies, which will interface with the ICS one. And the maternity strategy and the CYP strategy also need to interface to make sure that there's a continuity of outcomes through both of them for children. Thank you.
Thank you. Any further questions? Okay. Integration, Kate.
So from around primary care, that I wanted just to draw attention to, we've had the results in from the patient survey, and you can see in the top left, it is a really positive picture considering the year that we have had. And I think it's just a testament to the strength that we've got, again, referring to what I was saying to earlier about our practice relationships with their communities, which I think we undervalue, but I think it comes through. It comes through strongly in this as a consistent output that we have year on year, but it also, I think, is part of a broader conversation how we need to keep empowering our practices and developing them in terms of building that kind of locality integrated neighbourhood team focus. We deliberately, as part of the action, the board action focused on SMI and LD, and I think that there is still a lot. There's still a lot of thorny issues there that we do need to work through, and I think we've got some more concrete actions as part of today's conversations too. There's an enormous amount of work going on, but I think that we've probably got some new angles to take forward on that today, because the trajectory is going up, but the figures still aren't where we need them to be for our population. And the other piece that I was just going to mention is we are today actually finalising the expressions of interest for the vaccination programme going into phase 3, and we've had several of our patches that had stood down, standing back up again from a PCN delivery perspective. Yet to be confirmed, but I think it's a really positive move in terms of coverage and that different level of grip that you get from the primary care-led delivery model around the vaccination programme. I'm happy to take questions on anything else.
Questions, anybody? You're all very easily pleased today, I must say.
I know.
Yeah. Right. Thank you very much, Kate. And finance, Jane.
Yeah, thank you, Chair. So we had a detailed financial performance committee last week where we went into a lot of the background on the financial position. So I'll just give the headlines today. So we're reporting on the position as at month 3 in the current financial year, as at the end of June. Just as a reminder, we are still working in a financial framework that is very much affected by the COVID pandemic. We are operating a system of centrally calculated block contracts for our key providers. So the main ones for West Suffolk CCG being West Suffolk Foundation Trust and Norfolk and Suffolk Foundation Trust. And so those amounts of money effectively pass through the CCG, and we don't have the usual contracting round to negotiate those, which basically fixes an awful lot of our expenditure. We're also working on a financial framework that is only in place up to the end of September, the end of month 6, and we're awaiting news on what the allocations will look like for the second half of the year. All that being said, we submitted a plan that came to governing body last time where we were predicting a break even for the first 6 months of the year, and the month 3 report demonstrates that we are on track to do that. There are a couple or 3 main funding areas that lie outside our main allocations, one of those being funding for the hospital discharge programme. That's a sort of joint work between social care and the CCGs on continuing healthcare, funding for the vaccination programme, and as Paul mentioned earlier, the elective recovery fund, which doesn't have a huge impact on CCGs but has a much bigger impact financially on our main providers. Once we receive the expected additional funding through those routes, we are on track to break even as a CCG. As I say, I'll continue to update the governing body and via the Finance Committee as we hear more about how this will play out for the remainder of the year.
Thank you very much. Ed?
Yeah, we had a Finance Committee, which not all of us attend routinely. But we had a deep dive on prescribing recently, which I think would warrant a conversation in a clinical exec, if that was possible, Chair.
Certainly. Kate, do you mind taking a little action to ask Carol to bring
schedule that? Yeah,
the
and I'll talk to the
that
team.
discussion to a clinical exec?
Yeah.
Thank you. Any further questions? Okay, thank you very much. Governance and corporate, no, the governing body assurance framework, Jeff. No, Amanda, sorry.
Thank you very much. No problem, Chair. So here we have our July GBAF, and as we can see, we have 13 live risks. You will also notice that we do have an additional one this month, and that's relating to the white paper. Now, at the time of producing this GBAF, we were not aware of the boundary outcome, but now we know we can further mitigate the risks that are included. I think it's fair to say that we have got good traction around what we need to be doing in terms of transitioning to the ICS, around programme governance, as well as the CCG closure and the like. Huge workforce issues clearly, which will be worked through in greater detail and routinely reported back through remuneration committee, which will then report back to the governing body. We are also in conversation with our trade unions on how best to be working with them in partnership as we understand the implications more. And to support the white paper implications, we are still awaiting the HR framework, but we are told it will be at the end of July. So we wait with bated breath, and then we'll be working through and sharing with our staff accordingly. I think in terms of the other risks, a lot of them have been borne out through the IPR. And as we can see from the front sheet, a lot of the risks have been updated in great detail. Appended to the GBAF, we have our regular departmental risk register where we highlight the top 2 or 3 risks which relate to each directorate, which culminate through our ongoing risk forum. But I think I'll leave it there, Chair, but happy to take any questions.
Thank you very much. Anybody and everybody. Jeff.
Thank you, Chair. Just 2 small ones. Going through the GBAF and looking at the risk appetite, I noticed we're treating all of the risks except risk, whatever number it is, 27A, which says tolerate, which I'm a bit confused with. And I wondered if there's any update on the RAC issue, on the RAC risk, please. Thank you.
In terms of the former, Jeff, let me take that as an action and understand why we're actually just tolerating, unless I think it might be your risk. Lisa, do you have any comment on that regarding the CQC inspection for NSFT?
Sorry. I mean, I think that's probably an inaccurate representation, because I don't think we are tolerating it. So I think let me look at that, Jeff. It certainly doesn't feel like we're tolerating it.
That's what I thought.
Yeah, I'll have a look at it. Thank you.
And in terms of the RAC, Paul, did you want to make any comment?
Yeah, there has been, Jeff, there has been a few developments around RAC, but nothing to date that has substantially changed, if you want, our risk in terms of our assurance that everything that should be done is being done. However, we are currently reviewing that position with a conversation with the trust and surveyor discussions to understand the level of work that's gone on and the assurance. The trust is certainly carrying with their remedial work, and we're being given assurance that that is being completed. There has been some recent, should we call it, need for additional remedial work, which is being followed through. I plan to have another extraordinary risk meeting at some point in the near future, just to do a recap of where we are, to make sure everybody is comfortable with where we are with our risk. But as you can appreciate, it is a moving feast, and quite rapidly moving feast. But essentially, I would characterize it by saying, at this moment in time, there is no real substantial difference to where we were, other than the ongoing review of the building itself and the work that's been undertaken.
Okay, thank you.
Thank you. Okay, thank you. Governance and corporate business. Jeff, you usually lead us through the minutes of the meetings, that many of which you've been involved in.
There's an item of freedom of information, I think, first.
Oh, sorry, so there is. My apologies.
No problem.
Right.
Thank you, Chair.
Sorry, Amanda.
So here we have our regular report for the first 6 months of this calendar year on all of our freedom of information requests. And as we can see, we average about 20 per month, which is in keeping with previous reports shared with governing body. In terms of the type of information, again, very similar to previous reports, a lot of questions pertaining to commissioning. And recently we have seen the odd question relate to COVID vaccinations, particularly around how many vaccinated and the type of vaccine administered. But really a typical report, but happy to take any questions.
Thank you. Now, Jeff.
Thank you. Yes, we've got, as we normally have, we've got a range of committee minutes from the last few months, which had asked the governing body to endorse. Much of the content, I think we've touched on either in verbal updates or in reports at this governing body. So I'm not sure I want to go into much detail, but if there are any chairs who want to comment or take any questions, then fine, although I'm not sure we've got that many here. So I'd ask the governing body to endorse the minutes. Thank you.
Is everybody happy with that? Thank you very much. The next governing body will be on the 29th of September. At the start of this meeting, there had been no questions from the public. Jo, does that remain the case?
Yes, I haven't received any.
Okay. Thank you very much. In which case, that concludes the public part of the meeting. Shall we allow, are you all happy to